Well, I couldn't ask for a better introduction than Dr. Van Ace's comments about selecting individual patients and individual patient groups and experiments in nature to really teach us more about the etiology of cancer, as well as to give us information applicable to the individual patient and family situation. Certainly in studying natural variability and so forth, genetics is becoming increasingly important as we have more tools to analyze the various protein variations that he discussed, to analyze cytogenetic variations and so forth. And now it's certainly a cliche when someone refers to any disease, including cancer, as an interaction between the genetic background and the environment. So that when you study genetic variation, you have to try to be very specific about what type of genetic variation you're describing. Cancer really covers a wide spectrum of interaction between environment and genetics. At one extreme, we have hereditary tumors, tumors which seem to appear in gene carriers almost inevitably, no matter how wide the environmental variation may be. And while these are in general considered rare, they have a tremendous amount to teach us, not only about the individual patient and his individual family and pedigree, but also about mechanisms of carcinogenesis. Examples of this would include things like multiple polyposis of the colon, which certainly makes up a small number of cases of cancer of the colon, but obviously has important implications for the specific family involved as far as treatment, prophylaxis, screening, and so forth. If you look at a rarer cancer or group of cancers among the childhood tumors, such as retinoblastoma, those which are hereditary, follow autosomal dominant patterns, are a much larger fraction. So that by looking at rare tumors, you may be able to isolate the hereditary fractions more easily. But these generally make up a subgroup of probably all common cancers, so that when you talk about a common cancer, the hereditary ones are simply diluted out by the large number of non-hereditary ones, and any study of hereditary factors has to concentrate on certain subgroups and establish criteria for those subgroups. There are also hereditary disorders which predispose to cancer, but which obviously require something on the order of the stress mechanism of the G6PD deficiency. They're hereditary disorders in which there is an increased incidence of cancer, but certainly the cancer is not so inevitable as among the hereditary tumors. This is a large group of disorders could be listed, some of which we know a lot about, some of which we know very little about, but groups which have taught us something about roles which different parts of the body and environment can play in the development of cancer. The experiments of nature, such as the immune deficiency disorders, have really told us quite a bit about cancer. We know that in the immune deficiency disorders, not every cancer occurs more frequently, but specific cancers occur more frequently. All immune deficient patients do not necessarily develop cancer, only perhaps 10 or more % of them do. So they form a good group for study, even though among immune deficiency disorders we have a number of different types and so forth which have to be subgrouped. Another important group which are teaching us something about cancer are disorders in which there is an inability of the body to repair DNA damage inflicted by any different environmental source, perhaps UV light, perhaps something else. Xeroderma pigmentosum is certainly the classic example of this, although it's now a group of disorders. Another disease which seems to fall into this pattern in preliminary studies anyway, is Fanconi's anemia. These are disorders in which there is certainly an increased incidence of cancer and which lead us to hopefully understand something about the role of DNA damage, of somatic mutation in the treatment of cancer. Plus, within the individual families and pedigrees, there's much to be learned about genetic counseling, about screening patients, about susceptibility to various types of carcinogens and how one might go about trying to protect the individuals who is susceptible from these common environmental carcinogens. A group which may or may not be related, we don't know, are those which demonstrate chromosomal instability. We know that the unstable or abnormal chromosome background, whether seen in Down syndrome, where there's simply an extra chromosome, or in chromosomal breakage syndromes, we know that these backgrounds predispose to cancer in some way, but we do not know why. But they make an important group, individually and as a group, to study how the environment acts on these to cause them to undergo malignant transformation with the higher frequency than normal cells. There's a heterogeneous group of inherited growth disorders, such as neurofibromatosis, which there's a higher than normal incidence of certain cancers. It's inherited trait. We don't know what the internal or external differences may be, but again, we have normal cells which are not in a pre-malignant state, but certainly more apt to undergo malignant transformation, and which form an important group of cells to be studied. And lastly, you'll hear much more this afternoon about the enzyme systems which govern our body's response to the environment. It is somewhat similar to the G6PD story, but with an oncologic study, and that's the aryl hydrocarbon hydroxylase survey. This has been awfully important in identifying individuals who are more or less susceptible to certain environmental stresses. It's a hereditary variation, and it forms an important subgroup which can tell us a lot about the genetic environmental interaction in the development of cancer. And lastly, we have the hereditary tumors. We have those conditions which predispose to tumor. And at the other end of the spectrum, in the environmental end of the spectrum, we have interference with the normal mechanisms, such as immune suppression. We know these individuals develop a higher incidence of certain types of tumors. Again, they're sort of experiments in nature. But when you interfere with the body's normal protective mechanism, he is more apt to develop tumors. And we have the situation where an individual is simply overwhelmed, is saturated with environmental insults, such as people who experience doses of radiation or cumulative excessive doses of various environmental carcinogens, and develop cancer. May I have the first slide, please? To give you an idea of certainly a common cancer, skin cancer, which can have a number of different etiologies, and it's very important to try to define your genetic disorders and your environmental interactions. Talk about skin cancer for a minute, and what we'll say can be applied individually or as a group to both or all basal cell carcinomas, squamous cell carcinomas, as well as melanomas. But certainly conditions which predispose can include certain single gene disorders, certain polygenic conditions really rather than disorders, and certain environmental conditions. Next slide, please. Among the single gene disorders, this is not a complete list, but it's a list of ones which have had something specific to tell us about the etiology of cancer. As we mentioned, xeroderma pigmentosum, which has taught us about the body's ability to repair damage from outside sources, or the absence of the ability to repair it, and suggested that somatic mutation is an important event in development of cancer. The nevoid basal cell carcinoma syndrome. This is a dominantly inherited systemic disorder which includes a high frequency of basal cell carcinomas. It's a rare disorder, but if you look within the disorder, the systemic disorder can occur as frequently in whites as in blacks. But the protective mechanism of the increased pigment of the skin apparently protects the black individual so that he very rarely develops the actual skin cancers. He has all the other systemic manifestations, skeletal anomalies and so forth, but he very, very rarely develops the skin cancers. While among the Caucasian individuals, they develop an increased number of skin cancers, and the distribution of the skin cancers is very interesting. It's primarily in sun-exposed areas, and if the individual is subjected to other environmental carcinogens such as radiation, you can see an outline of the pattern of radiation formed by new skin tumors in the irradiated areas. So again, this suggests the increased susceptibility to certain environmental carcinogens, which may be applicable, the environmental carcinogens may be applicable to the whole problem of cancer in general. And understanding the mechanism by which the susceptibility to one is increased may have application to the whole problem of protection of the general population. Let me skip to albinism. That's simply an absence of any of the pigmentary protection which one needs or which protects one from the environment. The immune deficiency orders would be certainly a different role in the predisposition to skin cancer. Chromosomal instability, again, may be related to the DNA repair mechanism, at least in Fanconi's anemia. Hereditary cutaneous melanoma, we don't know much about the etiology of this, but it can be an autosomal dominant disease which occurs at an early average age and with multiple individual primary tumors, so that study of this at least is important within the individual and his family from the standpoint of his own prognosis and early cancer detection. So each of these single gene disorders has something entirely different but important to tell us about the individual, about his family, about possibilities for population screening and cancer control, as well as about basic mechanisms of carcinogenesis. So while these collectively only make up a small number of cases of skin cancer, they are much more informative than looking at 1,000 patients. Next slide, please. At the other end of the spectrum would be certain environmental conditions which predispose, and as we mentioned, these would be things such as immune suppression, interfering with the normal body mechanism, and excessive exposure to carcinogens, which just overwhelm the body's normal defense and repair mechanisms, apparently. Slide off, please. In establishing genetic studies, I would like to emphasize some of the things, too, that Ms. McDonald said. Certainly, any clinical study starts at the very background and basis of a complete history and physical examination and recording of this data on charts. Any genetic study has to have and start with a complete family history. The physical exam, it's very important to include any unrelated, seemingly unrelated anomaly, if any sorts of associations may be done by geneticists or epidemiologists or whoever. It's very important to take note of all of these things, because what you want to do, as Dr. Van Ace said, is to eliminate as many variables as possible when you study a group of patients or an individual patient or an individual family. You want to have as homogeneous a group as possible. And it is important to define a problem, to select the most appropriate method or patient population to study to answer that specific problem, to avoid a sort of shotgun approach of studying all genetic variables within all patients, because they tend to dilute each other out and lead to inconclusive and rather meaningless data. Let me outline a few of the types of genetic studies that have been done in the past and some of the suggestions for guidelines for getting the most meaningful data out of these studies. Next slide, please. Again, this is not a complete list, and there's some overlap. Family studies can be both laboratory-oriented or statistical. Certainly twin studies and linkage studies may fall under the category of family studies. We have association studies between all sorts of variables, which may be done among families as well as among patient populations or relatives of patients. Study of the immune system we've mentioned, and you will hear more about, I'm sure, this afternoon. In vitro studies, again, would probably be different types of association studies or studies on families. To go into a little more detail, family studies, the most classic examples in the past have included retrospective studies or pedigree analysis. And slide off, please. Retrospective statistical studies have been some of the earlier genetic studies relating genetics to cancer. And this simply involves studying the relatives of patients versus relatives of controls to determine the incidence of specific cancers or of specific laboratory anomalies among these relatives. You immediately run into the problem of what is a control. Do you try to select, quote, control families? Do you use population, age-specific incidence rates or whatever? And one has to solve that problem to even get started. This type of retrospective study is really limited by the way you define your population. Whether all tumors, such as all acute leukemias, are lumped together in one big group, or whether you're able to select out groups which will be comparable to other groups, to select out groups in which there is a genetic homogeneity as opposed to heterogeneity, to emphasize and exaggerate your differences. In discussing this, one has to consider breast cancer in light of the work that's been done here at MD Anderson by Dr. Dave Anderson versus what had been done over the last 40 years by other people. It's always been known that breast cancer tended to aggregate within families. Next slide, please. But next slide, please. I believe you skipped one. No, okay, never mind. It's certainly been known that relatives of patients with breast cancer had a higher risk than relatives of control patients or than patient-based population studies would suggest. However, any large group of breast cancer patients and their relatives revealed that the relatives had little more than a 2 to 3 times increased risk of breast cancer over the general population expectations. Now, this doesn't really tell you anything that's very applicable in a specific clinical situation, in designing specific laboratory tests, in counseling specific patients, or in understanding genetic mechanisms and cancer. It suggests a polygenic influence, which is very difficult to find and not very useful. However, this method can be useful if you use data gained from more specific studies, from pedigree studies, family studies, and so forth, which help you define the characteristics of hereditary tumors so that you can apply specific risks to relatives of specific patients. In pedigree analysis, Can you go back to the pedigree, please? I believe it's the slide immediately following this. Next slide. This is simply a pedigree of a nevoid basal cell carcinoma syndrome. And the sort of things that you want to look for are as complete data, of course, as possible, and it's difficult to get going back many generations, but as many individuals with specific clinical pathological diagnoses as possible. You expect to see the disorder in certain branches of the family and not in others. You expect to see equal sex ratios. You expect to see consistency in the disease within a family. When you have a specific pedigree, you can test your hypothesis. Is it a single gene disorder? You can look for genetic segregation. You can look for linkage and so forth, so that you can define a specific type of hereditary pattern from study of single pedigrees. Now, when you look at a number of pedigrees, certain patterns may emerge, and you may observe differences in the patterns at which tumors develop from the rest of the population of patients. Next slide, please. Well, this was out of order. I'm sorry. This was simply the earlier studies on breast cancer, which showed the 2 to 3 times increased incidence of cancer in relatives of breast cancer patients. And whether you looked at mothers, sisters, whatever, you came out with this 2 to 3 times increased risk, which was not terribly helpful. Next slide, please. If you look at pedigrees, specific pedigrees which show single gene segregation, you can define certain characteristics of hereditary tumors. And these are fairly true whether you're looking at childhood tumors, whether you're looking at certain adult tumors, even associations of tumors. Characteristics which allow you to select for the hereditary tumor patients include a positive family history of tumor of the same site, earlier average age of onset of the tumor for that specific tumor type. In other words, if the average age of breast cancer onset is in the 50s and 60s, when you've got a family in which are patients in which breast cancer strikes at age 22, you have to think there's something unique and different, and these are the characteristics that we see in the pedigrees of inherited breast cancer. And the last characteristic is multiple primary tumors, both of the same site as well as of other tumor sites. So that when you apply some of these characteristics, which we learned really through looking at individual pedigrees, when you apply them to larger populations in a retrospective way, you can come up with much more meaningful data. Next slide, please. When you apply these criteria to breast cancer, instead of the 2 to 3 times increased risk for certain relatives, when you look at the relatives of patients who have a positive family history of breast cancer and patients in whom the breast cancer was premenopausal and bilateral, you get a much greater increase in the risk of breast cancer to the relative. So you have really selected out and defined a group in which the cancer is much more likely to be hereditary. The risk is much higher to the individual and individual relative, and you have defined a group of high-risk patients in whom screening procedures and so forth are vitally important and feasible. Next slide, please. From this data, Dr. Anderson has described different types of hereditary breast cancer. Certainly these may not be all-inclusive. There may be overlap between these groups, but from clinical data and pedigree studies, he's defined at least 5 different types of hereditary breast cancer. Next slide, please. Using some of the same criteria, the family history, the early age of onset for an individual tumor, and the occurrence of multiple tumors also helps you define associations between tumors. In other words, when you're looking at an individual pedigree, which you assume has a relatively similar genetic background, and you see an association or accumulation of specific tumors, this information can help you to describe a cancer syndrome, which may relate to a specific gene defect, although the gene has different manifestations. And what we see are aggregations of tumors both within the individual as multiple primaries and within families who apparently have the same genetic defect, and which again follow an autosomal dominant pattern, which for each given tumor occur at an early average age, and in which the patients appear to be predisposed to multiple tumors. And these are simply examples of 3 families in which there is an association, apparently a common genetic defect, which predisposes to a group of tumors. Next slide, please. Which includes breast cancer, soft tissue sarcomas, brain tumors, acute leukemia, adrenocortical cancers, perhaps lung cancer, cancer of the pancreas. The important thing is to look for an association or grouping of unusual tumors which occur at an unusual age and as multiple primaries within families and individuals. Certainly it's difficult to select out lung cancer as an important part of the syndrome when it's such a common cancer. Slide off, please. A last type of family study, which I'd like to mention, which may be more important in the future, is the prospective family study. And in this age of computerization and cancer registries and cooperation on local, national, and perhaps international levels, this may be much more important and may help us to answer some questions of specific single gene defects. The best example that I know of in which this was very useful was really a key to understanding the hereditary pattern, which was otherwise sort of difficult to sort out, was in the childhood tumor retinoblastoma. And it, perhaps in a way like breast cancer, had long been noted to aggregate within certain families. It was thought to be due to an autosomal dominant disease which had extremely variable penetrance, and these vague definitions made it very difficult to apply any useful genetic counseling or screening to individual cases. However, in the Netherlands, where there was a small country, a complete registry, and follow-up possible on every affected patient, when the affected patients were followed and their offspring were observed, it was noted that they fell into 2 different groups, that regardless of the past family history, all patients who had the bilateral retinoblastoma had about 50% affected offspring. This is what one would expect if you have a dominant disorder with high penetrance, a good classic genetic disorder. If you looked at the patients, regardless of the past family history, who had single tumors, unilateral retinoblastoma, only about 10% of them had affected offspring. And once a positive family history was established, it continued within certain branches of the family. The laterality of tumors in the offspring was not dependent on the laterality in the parent. In other words, a parent with bilateral retinoblastoma might have a child with unilateral. But what it helped us to understand was that probably all the bilaterals and only a certain fraction of unilateral retinoblastomas were of the hereditary type, while a small fraction of unilateral patients did not have a hereditary type of retinoblastoma, so that you could define a specific autosomal dominant disease with all the implications thereof to a specific group of patients. And this has been very important as I mentioned, this is one of the criteria we've used in identifying hereditary patients. It's been very helpful and applicable in other tumors where we don't have such prospective studies possible. Well, there are a number of other genetic studies which can be undertaken, including various types of experiments in nature. Dr. Van Ace obviously mentioned the twin studies, which give you an awfully unique opportunity to look at sort of experiments in nature. However, there are a lot of difficulties involved in twin studies. Next slide, please. If one is undertaking a prospective type of study of twins, when you start out with a tremendous number of twins born, by the time you follow them until you have a number of pairs with breast cancer, you can see that you've really only gotten a very, very small number of patients left. So that number one, if you're trying to do studies comparing the concordance between monozygous and dizygous twins, and then beyond that you're going to select for breast cancer and specific subgroups of breast cancer, you're not going to end up with enough patients to really come up with significant data. So again, selecting a specific twin pair and doing specific studies within that pair is probably of much greater value. Now, there are cases where epidemiologists have been able to come up with large studies of twin data which have been very helpful. For instance, in acute lymphocytic leukemia and monozygous twins, there is a 25% risk to the identical twin when the leukemia occurs before the age of 6. So this gives us an idea that the acute leukemia before the age of 6 has perhaps a different etiology, or at least a much stronger hereditary component or fraction than the rest of childhood leukemia. So in that sense, it can give you a clue as to what groups to look at. But otherwise, it's a relatively difficult method to handle because of the numbers involved. So concentrating on one twin pair and designing studies to measure variables within that twin pair is probably much more useful than a large statistical survey of twins in general. A last type of family studies which can be employed are linkage studies. Slide off, please. People tend to get confused when linkage is discussed, and this simply means the idea that you have defined a tumor as a specific single gene entity, which obviously has to have some location on a chromosome and which may be nearby to another clinically definable single gene entity, which has no etiologic relationship. It may be eye color or whatever, or it may be some enzyme polymorphism, but there's no etiologic connection between the two, and it's a bit of a shotgun approach. It's a difficult study to undertake because you need extensive pedigrees with accurate data and good genetic polymorphism. However, in the future, we are learning more polymorphic variables, and with the advances in cytogenetics, it may be possible to determine linkage between single gene cancer predisposing genes and other types of genetic markers. This information would not be useful to a population screening study, but within a given family or pedigree, it could be useful in identifying those individuals who have inherited a specific cancer risk, and even to the point of genetic counseling and prenatal diagnosis could be very useful. I think this is still somewhat down the line, but there are people who are very interested in it, and I think it will, in the future, have some applications. Well, there are a large group of association studies. Next slide, please. Associations between genetic markers and tumor patients which have been employed in the guise of genetic studies in the past. And it's really awfully important to define what it is you're looking for. This can be a shotgun approach which comes up with very meaningless data, or it can be a very important, useful approach when done within specific families or specific patient groups. But you want to define your association studies as to whether or not you're considering a genetic variable and as to whether or not your population is genetically homogeneous. Genetic markers would include things like the ABO blood groups. People have looked for association between certain blood groups and certain cancers. Well, this had very little, the studies were started with very little etiologic considerations or ideas of nature of the association. And even when minimally statistical associations were found, it really didn't teach us very much about cancer, mechanisms of cancer development, association of cancer in the environment. It didn't help apply in specific families, so it really didn't teach us very much. On the other hand, some of Dr. Shaw's studies that he'll discuss this afternoon on the aryl hydrocarbon hydroxylase system, when he had a specific etiologic reason for studying the association of the enzyme system with the specific lung cancer, with the idea of measuring the body's response to environmental carcinogens, came up with a significant association between this enzyme activity and the development of lung cancer. This sort of study has wide application both to individuals as well as to population screening. So a genetic marker sort of study associating a specific marker variable and a specific cancer can either be useful or relatively not useful, depending on how well your model and program is in mind when you undertake it. Chromosomal markers, well, actually, this is a much broader field, including the whole field of cytogenetics, which has many, many applications, some of which are very useful and some of which are perhaps not so useful. The whole field of cytogenetics and cancer exploded when the Philadelphia chromosome was identified in chronic myelocytic leukemia, and then it was very quiet for a long period when not all tumors had specific markers, and there have been many, many ups and downs. But using cytogenetic studies on specific patients when there is a specific reason in mind for doing it can be extremely valuable. For instance, certain childhood tumors may be associated with a number of congenital anomalies in rare cases. And when specific chromosomal abnormalities are also found in these cases, it may be a clue to the location of the mutation for that specific cancer. It may give us a clue to how various cancers may develop, how they may react with the environment, whether it's related to a virus superimposed or whatever. But in specific instances, the cytogenetic studies can be very useful. But to simply do cytogenetic studies on every cancer patient has a very, very low yield. Certainly, histocompatibility antigen studies may be near and dear to some of your hearts, and certain associations have been discovered in certain groups of tumors, the acute lymphocytic leukemia and Hodgkin's and so forth. Again, it's important to bear in mind what you're looking for, what you expect this to tell you, and why, how you're going to use this data. There are a number of clinical markers such as congenital anomalies, acquired anomalies, various premalignant type lesions. Again, these may be important within specific families, within specific tumor types, within specific hereditary patterns, and if you look at them in the individual subgroups, there's much more apt to be important information derived than pooling all your information on patients from perhaps all leukemias or whatever. Certainly within some of the childhood tumors, we've defined specific subgroups of associations with congenital anomalies, which allow us to provide early screening, which have prognostic indications, which have follow-up and genetic counseling implications, but they're specific subgroups. Tissue susceptibility studies, this is the sort of thing such as transformation studies by SV40 on fibroblasts from patients to see the varying degrees of susceptibility as a possible genetic marker. That might be questionable, but again, if you know why you're looking at these particular patients instead of grouping patients, I think the results can be much more meaningful. There are a number of other things that could be included, things like looking at viral particles, looking at specific tumor antigens or fetal antigens and so forth. But if you keep in mind certain genetic principles and certain subgroupings of tumor patients, I think much more meaningful data can be related between the associations of the genetic variables and the specific tumors. Slide off, please. There's one more type of genetic study, just to briefly mention. It falls really more in the area of the epidemiologist, and that's studying geographical and racial differences of tumors in different population groups. What this can tell the geneticist and how this can help him set up some of his studies, though, might be interesting. There are some tumors which are relatively constant from geographical area to geographical area or population to population. One of these is Wilms tumor of the kidney, which is considered something of an index cancer by which we can base other cancers. Other tumors, such as Burkitt's lymphoma, show wide variation. Well, obviously, if you want to look at a tumor which has less, in which the environment has less input, you would select a tumor which is relatively constant over a wide environmental variation, such as Wilms tumor. While if you're looking at the environmental variables, you might look at Burkitt's lymphoma. And study of migratory groups, such as the Japanese breast cancer in Japanese women who come to America and the incidence of cancer gradually increases. Again, you're looking at a group that has a baseline incidence of breast cancer, which perhaps cannot be prevented by environmental variation, superimposed with environmental variables which apparently increase the risk of breast cancer. So these population groups can give you an idea of the relative input of the environment and the hereditary background. So that in summary, I'd just like to say it's very important to define your plan, your problem, the specific questions which you hope to answer by your study, and choose the appropriate population group. So that these questions can be answered, and to pose questions which have meaning both to specific patients, patients' families, populations as far as screening or early cancer detection is concerned, as well as to basic mechanisms of carcinogenesis. Certainly in the long-term future, one would hope that we can develop something of a genetic susceptibility profile. It's not hard to imagine that in the long-term future, while we're all going to be more or less susceptible to certain diseases and environmental conditions than others, if we're aware of what our individual susceptibilities are, then we can somewhat program our lifestyle to avoid those variables to which we're most susceptible. And it's possible to imagine a time when there are laboratory tests you can order, like a CBC or an SMA-12, which outline a patient's genetic susceptibilities, so that then he can enter into the appropriate lifestyle which protects him from those to which he is most susceptible. Does anyone have any questions?